Hello everyone. Thank you for coming and joining us today. This is a webinar to discuss the PHI program here at UIC and to show you from one of our alumni who have joined us today, so lovely, to talk about how they've used this degree to enhance their career and what they're doing in public health. My name is Sherry Wynewuth. I will be moderating today. I'm the Community Relations Director for Health Policy and Administration, which is the division in the School of Public Health that Public Health Informatics lives. First of all, I wanted to ask if everyone can hear us. I've actually muted everyone. If you can't hear me, oh, well, how would you be able to know? If you can hear me, please chat, use the chat section, or actually I'm going to unmute all of you right now to just see if everyone can hear us. Can everyone hear us?
Yes, I can hear you, Sherry.
Yeah.
Great, thank you. Does everyone know how GoToMeeting works? Basically what we're going to do is we'll mute everyone until the end when questions are asked, and then if you want to speak or write a question in the chat option, we'll read it out loud and share that information for everyone, and then hopefully Dr. Ed Mensa or Katina Dar can help answer those questions. To begin with, I would like to introduce, are there any questions at this time? Okay, great. To begin with, I'd like to introduce Dr. Ed Mensa. Ed received his degree from the university, his undergraduate degree from the University of Ghana, and his PhD from Iowa University in the Science and Technology Department. After his postdoctoral studies at the University of Chicago, he joined UIC and the School of Public Health in 1989 and was responsible for teaching and conducting research in health economics and information management. In 2002, he led a team of professors to develop the first online degree program in public health economics. The program has graduated 150 students from 35 states and 10 foreign countries with master's degrees, certificates in public health. The alumni work in places like the federal health departments, hospitals, university, NGOs, U.S. military, CDC, etc. Dr. Mensa also co-founded the only peer-reviewed journal in public health informatics, which is PubMed indexed, and the journal publishes scientific papers from major researchers in application of technologies to public health practice. Dr. Mensa is a member of the advisory board of the Illinois Health Information Exchange, the chair of the research and education section of the Health Informatics and Information Technology section of the American Public Health Association, a member of the American Medical Informatics Association, and American Economic Association. Welcome, Dr. Mensa. I'm going to turn your camera on. You're up. Stop looking at me. Look at the camera.
Yeah, thank you. We are here today to introduce you to the wonderful things that competencies and skills gained from this program can provide you in your workplace. As Sherry competently articulated, this program is the nation's very first informatics degree and certificate granting program in the country, and therefore most of the experts in the field now were trained here, from CDC, hospitals and universities, like she said. Find the practicing public health informatics today were trained beginning in 2002 when this particular field was just very young and nobody knew much about the American Recovery and Reinvestment Act, which ushered in a huge technological infusion to the healthcare field. You all know the stimulus program and the IRA and the High-Tech Act, the Health Information Technology for Economic and Clinical Care, which gave hospitals and health departments lots of money, $25 billion to implement information technology in their areas. Now, what happened? They implemented them, they needed skilled people. The skilled people we provided, this program has provided, I'm happy to say, our graduates were ready when the government was ready to put in money in healthcare. So you pretty much will be coming to a very wonderful program, as our alumni will tell you. And it's marvelous. Some of the places where our graduates are working are just unbelievable. And we have not only the master's program, we also have a PhD program in the field. So we are pretty much an all-encompassing program. And we try to engage our alumni in the deliberations, either as webinar providers, conference deliverers, and even instructors. So they leave the program, go to work, acquire more expertise, and then revisit the program and give the graduate students in the program some of the expertise that they have gained. That is exactly what we are going to give to you today. So you will see some of the wonderful things that you can do being here instead of being in health informatics or just being a regular IT guy who works in hospitals. We give you more than that. And so let me say, I'm here for a while, I cut it short, and I will basically sit and let Ms. Katina Daha take over, and I will answer questions later.
Thanks, Ed. Katina, I want to give an introduction to. She is one of our alums and has done some amazing things. She's an expert clinical information systems project implementation and manager. She's been implementing electronic medical records for large multi-facility organizations as a member of senior leadership teams. She's responsible for leading process change, improving work form, and facilitating the adoption of new computerized functionality and clinical decision support by clinicians across health systems. She collaborates with executive teams to define strategic direction of clinical information system projects and identifies the best methods for process and develops project plans. So Katina, if you're ready, I'm going to change you over. Thank you so much, and you're ready to go.
Okay, great. Thank you so much, Sherry. Let me know if you can see my screen.
We can.
Okay, excellent. And can you hear me okay? I'm guessing that's a yes. Okay, great. All right. So thank you very much, Dr. Menza. Thank you, Sherry. My name is Katina Daher. I'm the Director of Clinical Informatics here at Cook County Health and Hospital System. And I am also an alumnus of the Masters of Public Health Informatics program from UIC. Prior to that, I graduated from Wayne State University in Detroit, Michigan, and I was a registered nurse for about 20 years before I went back to school and got my master's. And I was in the first cohort of the Masters of Public Health Informatics program at UIC. And I'd like to tell you, I guess, a little bit about why I chose this program, because I was very, very conflicted and very indecisive, I think, for many years about what to do. So I was working primarily, all my clinical experience was in cardiology, cardiothoracic surgery, electrophysiology. And back in, oh golly, I think it was when my daughter was still at baby, I started working managing a lipid and a coumadin clinic in the North Shore over at Evanston Hospital. One of my patients happened to be Dr. Bernard Baum, Bernie Baum. He was the retired dean of the School of Public Health, and he was my patient for several years. And he was just such a lovely man, and he was always, telling me, Katina, you need to go back to school. You need to go back to school. You need to do something more than what you're doing today. And I kept telling him, I don't know what I really, really want to do. I'm not convinced that I want to be a nurse practitioner. I'm not convinced that I want an MBA, and frankly, I'm not sure exactly what I want to do with my life. And, you know, he kind of kept nagging me for some time. And if you knew Dr. Baum, you would know he was a pretty convincing person and just a very charming and caring individual. So he said to me, so what are you thinking? What do you want to do? And I said, you know, honestly, I don't know, but I know it's not an advanced, you know, APN degree. It's not an MBA. I want to do something with computer information systems. I just do. I know that there's something coming. I know we're on the beginning of a big wave in information technology, and I had seen this because my husband actually was in IT, in the finance industry for many years, and I knew, you know, that we in healthcare were kind of behind that trend. So you know, instinctively I knew IT was kind of where we were headed, and it intrigued me. And one of the things that I learned, managing my small lipid, you know, clinic cohort of patients, Coumadin patients, I started using these small software tools, and they were able to give me information, not just data. They gave me information, and what was really amazing was when I could run the reports and I could see how many of my patients were at goal, how many of my doctors were managing their patients well, you know, and so on. So the reporting capabilities of even these little software tools that I had my hands on back in the day, which seems very long ago, I found them to be very powerful. So this always intrigued me. And then, you know, one day Dr. Baum came to, you know, have his INR checked, and he said, Katina, you know, there's this program that two of my colleagues are developing, and he introduced me to Dr. Croak and Dr. Menza, and Dr. Annette, and I can't remember her last name, Annette, Dr. Menza, you'll have to tell me Annette's last name. Anyway, these three professors were developing this program in public health informatics. It was a master's in public health informatics, and they were actually recruiting clinicians at the time to become part of this program and to expand their studies. So I looked at the program. It was what appeared to be a really good fit for where I wanted to be and what I wanted to do, and just kind of dove in and started the program. And when I first got in, I practiced as a clinician for 1 year, and then my second year in the program, I thought, this is it. I'm going to take a leap and stop being a clinician and try and get a position in informatics. So I started working at Rush North Shore Hospital, which is now also part of Evanston North Shore University Health System, which is now becoming part of Advocate Health System. I was a clinical information specialist at Rush North Shore, and I started becoming responsible for information technology projects. And at that time, that organization did not have an electronic medical record, but they did have pieces of information systems. They weren't connected, they weren't really talking together, but they were still important and effective. And the first project that I took on that was a big project for me, you know, just kind of getting my foot in that door of being in informatics, was to implement a surgical information system. And it was huge. It really was huge. In hindsight, I didn't realize, I think, how big it was, but it was huge. It involved every aspect of what our surgical services were doing, and it involved everything related to scheduling, to material, to charging, to clinical documentation, you know, intraoperative clinical documentation. So I really, really started understanding what I was learning in school. And what I was learning in school was a lot about relational databases, about networking, how computers are connected to each other. I remember going in and opening one of the closets with our IT guys, and I said, I want you to help me understand because I'm reading a chapter on networks, and I want to see these cables that they're talking about and the racks and the servers and this and that. So it was really wonderful to be able to apply everything that I was learning in school while I was involved in kind of a hands-on, day-to-day work. So while I was at Rush and implementing these small, kind of not integrated projects and software, I learned a lot about project management. And this is an important skill. I mean, you all need to really, really appreciate when you start working in this field that it takes a lot of teamwork, and it takes resources and human resources and financial resources and a lot of coordination to really, really implement these software applications, to get your users to understand the workflow, and to get your IT people to understand the workflow of your users to be successful. So project management, you know, is a really big and I think important part of what you can and should learn, whether it's, you know, through your classes or through your hands-on experience. You really, really need to be able to lead teams and coordinate something from beginning to end and be able to make all of the pieces align so that the dominoes, you know, fall in just the right place. So that was an important part that I learned. After being at Rush, I went to work as a clinical strategist for Cerner Corporation. I don't know what compelled me to do that, but it seemed like a really good idea at the time. So I spent 3 years at Cerner, and I really learned from there, I think, the importance of being able to and design all the workflow for an electronic medical records implementation. So my role at Cerner, and this involved, you know, getting on an airplane pretty much every Monday and traveling to client sites in wonderful and exciting places like Fargo, North Dakota, and Midland, Michigan. It was very exotic. Not at all, but it was interesting. I learned a lot. So I traveled for almost 3 years every week and worked with different people, and it was really, really amazing how every project, every group that I worked with, every project, I think, had its own personality. You know, different people, different circumstances. Every hospital had slightly different workflows. Their lab processes were different. Their radiology processes were different. Their registration process. So from one client to the next, you know, our goal on my team was really to partner with them, help them understand, you know, the importance of implementing something as big as an electronic medical record, because it just changes everything that they do, and trying to leverage, you know, all the tools that we had to put them in a better position of how they work and how they document, and then moving on to what to do with the valuable information that they're actually collecting. So that was an interesting part of my life, 3 years with Cerner. And then somewhere in kind of the tail end of that 3rd year, I was contacted by my old director of nursing, and she said, I'm creating this new position. It's a position we really, really need here because we don't have anyone really representing kind of the more nursing, clinical, informatics side of projects here in our health system, and we are in kind of a full-blown EMR implementation, and we don't have any real clinical voices helping the IT department and helping our officers. So she literally had created this position, which I thought, again, was a perfect fit for me. And I ended up leaving Cerner and coming to work here at Cook County Health and Hospital System. So my role currently here is to be that middle layer, kind of the liaison between our IT department and our clinical people. That involves our nurses, our doctors, our lab technicians, radiology, everybody on the user side, and then everybody on the IT side. So we have an IT department that has no clinicians. These are all technical people. Some understand hospitals, some understand healthcare, some don't. You know, it's a mixed bag. And then we have all these end users. So my role here is really to oversee all aspects of design, build, test, training, conversion, anything related to our electronic medical record and our health information systems. And we have a little bit about our health system. You may already know. I think we're like the third largest public health system in the country. We have 2 hospitals. We have 19 physical locations where we see patients. We have about 100 clinics within those 17 locations. And we also are responsible for CERMAC, the jail, all the health services offered at the jail. We're responsible for about 600,000 ambulatory visits per year, and we're also responsible for the Cook County Department of Public Health. So Cook County Health System is a huge health system, and it touches a lot of people here, the County of Cook. My role reports to the CIO, the CMIO, and the CNO. So that would be the Chief Information Officer, the Chief Medical Information Officer, and the Chief Nursing Officer. These are kind of my 3 colleagues. So enough about that. I wanted to talk next a little bit about how this all ties into public health informatics. So from my perspective, we have spent, I think, the last probably 10 years, at least a solid 10 years, implementing electronic medical records across the world, right? Everybody's got an electronic medical record now. There are very few people that still are working on paper. So the electronic medical record, as far as healthcare is concerned, is like the foundation of a house. I call it the brick of the house, right? The building blocks. This is the foundation because it's really important to collect your data, collect discrete data that you can actually report on, and to collect good, clean information from your end users, right? So we can't have a bunch of free text, mumbo jumbo, because we know we can't report from it. We know we can't have situations where our clinicians aren't putting in good information, junk in, junk out. So it's really, really important to have a system that collects discrete data, and it becomes a big, big repository. So we have, like I said, I think across the world, not just in this country, but across the world, we are taking people off paper and saying, put your information here in these electronic medical records, and just start using these tools that now are bringing you into the 21st century. And don't forget, banks have been doing this for tens of years, right? 20, 30, 40 years. financial institutions have used electronic systems well ahead of those of us that are in healthcare. So we're behind, but I think we've caught up very quickly. And as Dr. Menza said, meaningful use, high tech, all those things that have helped to push people along and try and fund them, and all of the regulatory requirements that are coming with meaningful use have really, really pushed people to say, yes, we're going to use electronic medical records, we're going to use them in a meaningful way, and we don't want, so the incentives are now diminishing, right, and now these programs are becoming penalty programs. So meaningful use has been a big driver behind getting organizations to get off butts, basically, and really embrace information technology. So we've moved from just collecting data now to trying to do something to help our clinicians, our staff, our patients to intelligently filter and present what we call clinical decision support at the moment of care where it's needed. So something as simple as I'm entering an order for a medicine, my system, crawls through the information, looks at LCDs, et cetera, and then presents an alert to the provider saying, your patient has an allergy to this medication. Are you really sure that you want to do that? So we're moving into a higher level of clinical decision support and doing a lot of very cool things with rules and pop-ups and alerts that really are taking healthcare from just being based on memory or paper, digging through paper to try and get information, to saying, I'm going to present this information to you right at the moment when you need it and help you to provide better care. So clinical decision support is becoming much more robust. And then from there, I think the highest level of functionality and kind of a newer wave that I know we're seeing now, and maybe those of you that are already doing other things are already there, but I know we're kind of just getting there, is beyond clinical decision support, then we have business intelligence. So recently, we've created a business intelligence team here. And it used to be some of our old kind of report writers, and now we have other data scientists, and we've added other members to the team. And so this is our, I guess I'll call them our elite SWAT team of analysts and scientists that are taking all this information that we've been collecting now for 10, 12, 14 years and saying what is meaningful to us, what are we doing with our patients, what can we do differently, and what should we do differently. And just so you know, I mean, from our perspective, our organization is now looking to population health management, so we're also now shifting from saying we're going to put all the focus in the hospital, acute care, emergency department, trauma, which of course we've always done. I mean, we're very well known for our trauma response here and our ED, but as an organization we're saying there are hundreds of thousands of people that shouldn't be in the ED, they should be in the clinic, they should be in a patient-centered medical home, and we should be taking care of them in such a way that we keep them out of the hospital. So our emphasis has really gone to population management, accountable care, and patient medical home, which is really a very exciting time for us. It's a very natural transition that we think we should be keeping people healthy instead of just taking care of them when they're sick. And, we're notorious, especially as a safety net hospital, to only taking care of people when they're in the worst shape. And in reality now, we're really trying, and hopefully with, county care and other insurance products that are becoming available, extension of Medicaid, that we can actually turn our focus and provide care to those people that are out in the community that really need more wellness than they need emergency medicine care. So very exciting time, and we're all very, very enthused, by this new mentality. So I wanted to give you, sort of to close or to transition, a few examples of what I mean by clinical decision support and a few things that we've been working on. And these actually have evolved over even the last few weeks. We're still making changes right now because of the whole Ebola thing and the hysteria around Ebola. But nonetheless, we are getting ready. And before Ebola, we have to talk a little bit about influenza, right? We're also at the beginning of our flu season here. And these are two things that are literally just now unfolding in our hospital as of this week. So I thought I would use these two examples when Dr. Menza and Sherry asked me to speak. I was kind of scratching my head, what would I talk about? And then I thought, oh my God, here we go. Perfect examples of something that is literally evolving in my organization right this minute, and it has everything to do with public health. So in our organization, we have not so hot influenza rates. I don't know why, but we cannot seem to immunize enough of our patients. There are many barriers. Some of them are cultural. Some of them are just operational. I don't know exactly what's behind it, but we've always struggled. We've always struggled to get our immunization rates up to the kind of rest of the country. So a couple of things that we did are to create these rules that are firing. We started first in the hospital. We said, okay, on admission, every time a patient is admitted, we're going to, anytime anybody writes an admission order, we're going to look in the database to see, is it flu season? Yes. Has the patient received an influenza injection in this flu season? Yes, no. And then if no, please fire a rule that says, oh, we also look for egg allergies. Forgive me. The rule also looks for egg allergies. It looks for allergy to the product. And then it says, okay, this patient needs to be immunized. So we pop an alert that says this patient doesn't have a documented flu vaccination. And we literally place the order for the clinician to say, we've added this order, please go over there and initiate it. And all they literally have to do is click OK. The order is placed on the patient's medical record. And of course, like I said, it's done the allergy checking, it's done everything else. And then it presents the provider with, and this also fires to our nurses because we have protocols in place that say they can immunize without having to get permission from a doctor. So it places the order on the patient's chart. It looks at the age of the patient. It says they should receive this product, which could be a trivalent injection. It could be an intranasal potentially. If it's a pediatric patient, it selects the pediatric product and dose. So very powerful. It's already done all the work for the clinician, and it says, please place this order and move forward. So we're very, very excited to see, with this rule, are we going to be able to move the meter and immunize more patients this year? So it'll be very interesting. We don't know yet. I'm sure we will because it's made it very simple. So we've eliminated some barriers, and we're hoping to really get a much better outcome. And we won't know until probably April, but we're actually collecting data, I think, every week now still, so we should start to see some trends. So while we've been working on our flu rule, which was actually quite complicated and took a fair amount of effort from our IT folks to put together, there was much more complexity to this rule than we imagined. At the same time, Ebola happened, right? Oh my God, Ebola, Ebola, Ebola. It's like eating the world. So we had to do something immediately about Ebola, and this we're hoping to go live with either tomorrow morning or Monday morning. We said, okay, we've been asking, some of our centers have been asking at the point of registration if the patient has been exposed, have they traveled, et cetera, but we weren't really documenting this very well. So we designed just now, literally in the last 7-9 days, I think this has been going on, three screening questions that we ask everyone at every point of entry. And again, we're using a rule in clinical decision support to fire if so we've combined, which I don't know if this is a good idea or a bad idea, but we've combined Ebola screening and influenza-like illness screening, all in a matter of 3 questions. So the first question is, do you have a cough? Yes or no. If the answer is yes, a little alert pops up, says, give the patient a mask. You know, there's simple things we can do to help prevent transmission to our staff, to other patients. Put a mask on the patient. Not so much put a mask on the patient, but give the patient a mask, because they really should have a mask if they're coughing. Next question is, have you had a fever recently? Simple, yes or no. If the answer is no or yes, it's irrelevant. The rule continues to the 3rd question, and it says, 3rd question is, have you traveled to Liberia, Sierra Leone, or Guinea in the past 21 days, or had contact with a person? So it's a mouthful of a question, we know, but it's also scripted so that the clerks can ask these questions, get a simple yes or no, and then we can determine if the patient is at risk. If the answer to fever is yes, the answer to travel to West Africa is yes, then a little alert pops up, patient is at risk. Please give the patient a mask if they haven't already gotten one, and then move the patient to an isolation room, call your charge nurse, attending doctor, or supervisor. So this is just meant to say, we have a patient at risk here, isolate them, and then be able to evaluate them from there. So it's very powerful. It's simple. This particular piece was simple, but powerful in terms of getting, A, the communication out, B, getting the alert out. Now, unlike in Texas, we did push this information through, so we collected it at the point of registration. We pushed it through to a flow sheet, so now this information is visible to all the clinicians. Unlike the criticism in Texas that the information wasn't shared from one part of the chart to another, we're actually pushing it all the way through to all different parts of the chart, so it's visible and at the fingertips of our nurses and our doctors. So it's going from the clerk, the nurse, to the doctor, and so on. And then from there, we push the form, and they're able to view what the clerk presented, and then they can validate it or dispute it, and they get the same alerts. And then it's also pushed to the physician documentation. And then from there, okay, this is just another view of our physician documentation. And that's it. So our next steps will be to really look at our data and say, did we make an impact on improving our immunization rates? What can we do better with our technology or our workflow, and figure out, you know, maybe things weren't firing at the right moment for the clinicians, and we can make adjustments. And then obviously with regard to Ebola, you know, were we able to prevent any transmission or any, to see if we were even able to identify anyone that presented in our health system that could have been at risk. So that is all I have, and I think we're good on time, so that's perfect. So that was my example, my real-life example of how I think I've taken some of my skills that I learned in school and able to use them in not only this job, but all my previous jobs in informatics. And that's all I have. So
Thank you, Katina. That was great. I'm going to actually change us back to our screen.
okay.
And I'm going to put Ed Mensa on webcam. And
For a couple of
I
minutes.
am opening it up. I'm unmuting everybody. And also we'll be monitoring the chat. And please, we're open for any questions that you may have. Anyone? We do have a few questions that came in prior to the event starting, and the first one was, what are the key differences between traditional IT and informatics? And I'm going to leave that open to you, Ed and Katina. So, I mean, which one would like to? Ed wants to take it, Katina, but please feel free to jump in.
Yeah. Okay, yeah, I got to take this one. Yeah, traditional IT, information technology, is mainly about computers and network systems, so it's close to hardware with a few software components. So if you put the machines, which is the computer and the network systems and the peripherals and the software that they work with, you still have information technology. Informatics is not computers. You use it sometimes. Now these days we have to use it. Yeah, so informatics is not computers. Informatics is about data acquisition, retrieval, storage, processing the data into information and decision support systems that you can use to make efficient and effective decisions. So in any discipline, there is informatics. So if you take even the banking, they have to acquire data on clients and analyze those data and find out which products are working well so they can advertise towards the people who consume those products. That they do in informatics in direction. In healthcare, we acquire data. Anytime you see a physician, they collect a lot of information about you. And that information must be stored so that we can retrieve that data, must be analyzed on an individual and on a population basis so that we can see what the information is telling us, what the data are telling us. That will only come from analysis. And then when you see what the data are telling you from the information you got out of the data, then you can use that newly acquired information for better decision making. Mathematics is always about using data, acquiring data, storing data, processing it, and finally getting information that you can use for decision making. So it's actually the big honcho now in the room in terms of every particular healthcare field. Informatics is the real deal.
Right. So would you say it's like almost a book is the paper and the binding, and that's IT, and informatics are the words written in the book?
The words written in the book and the information that you take from the book.
Okay.
You read the words, some people have different meanings for it, so the meaning you take from the book after opening, reading, and that becomes the informatics. So right. It's marvelous. Take a look at this, the guy who came to, the Ebola guy, who came to Dallas. They entered his data into electronic medical records, EPIC, and according to what we heard at first, the physician did not see what was entered, that the guy had been to Liberia. So they didn't take that portion seriously. They did other things, and they gave him antibiotics, and he went home. Okay, if they had an informatics application, that data that was entered into electronic medical record will now create an alert system which will show up in the physician's portion of the database. So when the physician opens up, comes to treat, the first thing that he sees is this alert, danger, red. This guy has been in Liberia. Straight. We all know what is in Liberia. That process is informatics. But just log in the data into a computer, it's IT.
That's great. Hey, Katina, do you have anything to add?
No, I totally agree. And I mean, for me, it's always been the so what factor, right? So data by itself doesn't have a lot of meaning, but when you put it all together, as Dr. Menza said, then it becomes something much more powerful. It becomes information, and you're able to answer the so what question. So what does it mean? What does it mean to me? What does it mean to you? And it becomes meaningful. Like you said, data is like one element, one letter, one piece of the puzzle. Information is the big picture, the meaningful part, the part that we can make something actionable. Because without it, it really is nothing but a collection of meaningless information. So I think it's everything that glues the big picture together. So totally agree.
Thank you, Katina. We actually have a question that just came in. Is there a margin of error, and how do you account for human error when using data? That's an excellent question. So is there a margin of error, and how do you account for human error when using data?
Well, that's Katina handle that, because she is dealing with human error in the hospital every day.
Yeah. So Katina, what do you think of that question?
I can jump into.
Yep. So yes, there is human error. There's always human error. There's only so much I think that we can do with informatics that to help people do the right thing. There's only so much that we can present to someone to help them right decision. Yes, there are human errors. They happen every day. They happen to clinicians every day. It's unfortunate, but there's nothing that makes it 100% proof. This is a human science, right? The margin of error for me is zero, right? We're in a field in healthcare. There is zero. We don't tolerate that. We don't accept it, and we don't aspire to it, right? Our tolerance for error when we're taking care of people where we can do harm is zero. So this is another important facet, I think, of informatics, that you can harm people if you do the wrong thing with your information system. You can actually create a situation where you set up a mistake. You know what I mean? You don't do it intentionally, but you can do it. So our tolerance is zero. Our margin should always be zero, but it isn't, because we are human, and human mistakes happen. Errors happen. People click in the wrong cell in an electronic medical record and put misinformation there. So when you're looking at it, you're thinking, oh my God, did they really mean to say that? And then you have to go back and kind of, ask the person, audit the chart, and pull it all together, because I don't think there's anything that can replace the human brain or the clinical instinct of a clinician.
So how do you account for that? Do you have protocols set within systems that look for like 2% margin of error or something along those lines, or that would be my question.
Yeah, you can build parameters into things to alert you when somebody is putting in an inappropriate value. We do that with medication orders all the time, where we know that the range of something should be 10 milligrams. We don't allow someone to put 100 milligrams, right? So you limit the number of characters you can have in that field to 2 instead of 3, right? We don't want to set up a mistake and allow someone to put in 1,000 milligrams when they really meant to put in 10. So there are controls within the build of each data element and parameters that you can set. And we do it all the time for pediatric patient dosing. We do it even for, we're thinking about implementing a rule now that looks at the margin of change from a person's weight from one visit to another. because we have people always putting in kind of wrong heights, wrong weights, therefore we can't calculate BMDIs. So yes, there are many, many things that you can do from an IT perspective to help control that.
Oh, that's great.
That's wonderful.
Was the question answered? Do you feel, Lois, do you feel comfortable with that answer, or is there another follow-up you would like in terms of that? All right, well, thanks. We'll move on. We had one more question. It was, why public health informatics and not just health informatics?
Well, let me take that.
Okay.
And look, public health informatics, like I said earlier, informatics is a system of doing things, using information processing to create, data processing to create information to have a meaning to what you're doing and do them very effectively and efficiently. Now, if you're dealing with health informatics, actually is we used to think health informatics is separate from pharmaceutical informatics or any type of informatics. You could say it is the it is the umbrella under which all types of health belong. The biomedical people will tell you actually it is biomedical informatics, under which we have health informatics, public health informatics, pharmaceutical informatics, dental informatics, nursing informatics, that kind of stuff. Yeah. But I would say health informatics deals with the clinical side, the treatment of person by person clinical side. The public health informatics deals with the population health, the public side. So public health informatics will mainly be using the health data for surveillance purposes, using the health data to create educational programs to target and educate population of people rather than the individual person. So when we concentrate on the individual, we used to call that part health informatics. When we move into the population, particularly if you take a look at this American Recovery and Reinvestment Act and High Tech Act, federal government gave all that money so that there'll be a convergence between the clinical side and the public health side. So patients can now have a continuum of patient treatment, and the data can directly go to public health agencies for them to design surveillance models to track those patients in those populations that may be susceptible to the disease. So the public health folks will take what they do as public health informatics because they are doing the population. But having been in this business for quite a long time, I'm beginning to have problems demarcating them too much. There's a difference. One is more clinical, one is more public, but they are almost together. You know, they revisit each other with data coming from the clinics, from the health informatics or clinical informatics discipline to the public health hubs, and they use this data to create other alerts and send the alerts back through the electronic medical record to the health informaticians, to the clinicians to treat the patient or to help them treat the patient they are seeing right now in front of them.
Right.
Okay, so the short answer to your question, which I may not find definitive, is the old demarcation that health informatics is medical and clinical and public health informatics is population health and the public. But somehow the two...
Well, and to your point, in today's environment with the Affordable Care Act and different elements related to the importance of population health in every healthcare center, I could see that being a really critical piece of future health informatics.
Katina is doing that every day.
Right, and that's what I was going to say. Katina, is that do you kind of see that in your position that population health and having a public health background is helpful?
Absolutely, absolutely. I think there's been just that huge shift, and again, it's relatively new, even though I know Dr. Menza's been in public health, so his vision has always been that of someone in health. But I have to tell you, having been in healthcare, you know, as a nurse, and thinking back to what we did when I was a new grad, you know, coming out of school and being a nurse, and where I now 30 years later, and even in the last, I would say, years, a tremendous shift toward toward population health. I mean, if you read anything today, it's all about population health, and what a wonderful idea, right? I mean, and why is it a novelty? I guess is my thought after all these years of what we do in terms of taking care of people. Why is it a novelty to us that all of a sudden we think we shouldn't be taking care of patients in hospitals, that we should be taking care of them when they're well and they're out there and they're in the community and keeping them out there? And, you know, insurance companies, unfortunately, I think have been drivers of that, you know, where they never paid for wellness. They only paid for us when we got sick, you know, and we needed something from them. And now they've, I think, learned, or over the years, I guess the mood has changed, that it's all about population health and all about taking care of people while they're well. So it's very interesting.
Yeah, it is. I would like to say that it's because you and Ed are both visionaries that you knew that this was the right path and what you were doing.
She was our star alumni.
And
Okay?
people have finally caught up to realize exactly what you said. I mean, it's natural. It should have been in place forever. So I'm going to open this up. You know, those are the only questions that we have received. Is there any other question? Because we are at noon. If there's no other questions, we're just going to say thank you to everyone that's attended. We'll be making this available to you. Sue Haas will be sending an email to everyone to let them
Thank you,
have
Katina.
access to
Thank you a
this.
million times for making your skills available. I always admire the way you participate in our program and giving something back. Thanks a lot.
Yes.
My pleasure. Thank you.
And thanks to everyone that's joined us today.
Very good. Thank you, everyone.
Yeah.
Bye-bye.
Bye.
Okay.